Hello, everyone, and welcome to the Maternal Health Echo Series. This training is brought to you by the Center for Substance Use Training and Telementoring, CSTAT, a division of the Be Well Institute, in collaboration with the Perinatal Psychiatry Access Network, PeriPAN. My name is Andrea, and I will be helping to facilitate this conversation today. Before we start, I want to remind you that this session is being recorded for later distribution, and you will find it later at our Be Well Texas YouTube page. To help us with attendance, please enter your names, email addresses, and affiliations on the chat. It is important to have your identifiers on the chat, especially if you're seeking CEUs or CMEs after today's class. And our didactic today is presented by Dr. Kelly McGlothen-Bell. We want to welcome Dr. McGlothen. Dr. McGlothen is going to be presenting the didactics. After that, we're opening the floor for your questions and comments. And then we're moving to a case presented as well by Dr. McGlothen. Again, we want to hear your perspectives, your ideas, your opinions on the case. We're going to discuss a little bit about that case along with our didactic presenter. And then we'll move to announcements. After that, our lead expert, Dr. Anastasia Ruiz, she is going to be giving us a brief summary of some of the recommendations shared by all of you in this group about the case. So right now we're going to start with some introductions from our experts. Let's start with Dr. Humphrey. Welcome to Maternal Health Echo. Would you like to introduce yourself today?
Hi, I'm Dr. Emily Humphrey. I'm a DNP. Right now I'm based out of Waco, Texas. And I've spent 12 years doing various forms of addiction medicine on the both inpatient and outpatient side and with pregnant women.
Thank you, Dr. Humphrey. Dr. Reese, welcome to Maternal Health Echo.
Hi, thank you for having me here. I am one of the PeriPAM faculties and regional medical director of PeriPAM in the West Texas region. And I worked at residence. We treat women who are planning to get pregnant and postpartum for their mental health conditions, as well as substance use conditions. Thanks for having me here today.
Thank you, Dr. Reese. Dr. Alag, welcome.
Hi, thanks for having me here. I'm one of the addiction-trained psychiatrists. I'm very excited to be here and to hear this presentation as well. Sorry about the background noise. I have my kiddo, so please bear with me.
It's okay, no problem. And Joyce Subrain, would you like to introduce yourself to the group, please?
Hi, good morning. My name is Dr. Joyce Subrin. I'm a doctor in behavioral health and a licensed master of social work. I apologize, I'm working from home today. You can probably hear some activity. I've worked in women's health over 20 years, inpatient and outpatient, working with women in a special clinic called Moms Over Medicine, where we support women who are in recovery, early recovery, or want to obtain recovery. So this is a great case. Thanks for having me.
Thank you, Dr. Subrin. And we're going to introduce now our presenter of the day, Dr. McGlothen. Welcome to our series. I think we could start sharing your didactics.
Perfect.
If you want to briefly introduce yourself, welcome again.
Thank you so much. Yes, let me go ahead and share my screen now. Give me just 1 second. All right, are you guys able to see?
Yes, we see it.
Perfect.
That's good. Thank
Perfect.
you.
Okay, excellent. Well, my name is Dr. Kelly McGlothen-Bell. I am an assistant professor at UT Health San Antonio School of Nursing. Been in that role for about 4 years now, but also trained as a high-risk maternal child nurse. Worked in that space for about 10 years, as well as a lactation consultant. And I'm really excited to have the opportunity to speak with you all about navigating tangential systems for families affected by substance use. Specifically, how do we collaborate with child welfare and criminal justice systems as healthcare providers? And so my research in and of itself has always focused on families affected by substance use, specifically those during the pregnancy and postpartum period. But more recently, I've moved into looking at policies and how they might either help or harm families, specifically what the outcomes of the policies have on families' health and their outcomes. And while this research area is fairly new to me, as I mentioned before, I do have a lot of training as a maternal child nurse. And within this role, I did have few interactions with child welfare. As I became a new nurse, that was really at the height of what we were calling the opioid epidemic back in like 2012, 2013 timeframe. And so I had lots of interactions with families coming within our system who were affected by substance use. Now, I had even more interactions rather than child welfare, but actually with our social work staff. And for the life of me, couldn't understand why, although I was one of the ones on the front line with these families, spending lots of time with them in the interpartum setting, why was it that whenever a report was made or when information was being given to CPS, why I wasn't also involved in those conversations, as I felt like I could help to hopefully advocate for families. And then another question that always came up for me was what happens to these families once a report is made? Oftentimes, as you likely all are familiar with, as healthcare providers, we don't get to see oftentimes what happens after these reports are made. And so those questions always plague me as a nurse. The limited scope sometimes that we have as healthcare providers, excuse me. Um, and likely for many of you, those questions remain unanswered. And so, as we begin to have a conversation about how do we work more collaboratively within these different systems and structures, I want to ask you to take a moment just for a second to think about a time where you had a patient who required coordination of care with another system. Maybe that was child welfare, maybe probation or social services. Think about what went well within that interaction, and then what made that interaction more challenging for you. And we'll just pause for just a brief moment to think about that. As we're continuing our thought, my hope for today is that we'll explore these strategies that will help to strengthen collaboration and hopefully advocate for collaboration that is more equitable, trauma-informed, and helps us to work across silos that are work across systems that are oftentimes siloed. And so as we get into this, forgive me, I do have a little bit of a cold here, but I do not have any disclosures. Our objectives for today will be to explain how child welfare and criminal justice systems intersect with healthcare for families affected by substance use. We'll also recognize key challenges and barriers that may hinder effective cross-system collaboration. We'll talk about implementation of trauma-informed family-centered communication strategies when engaging with systems-involved families. And then hopefully you'll be able to take away at least one actionable step to help strengthen interagency collaboration with our own practice and organization. It's my hope that as we move through our discussion, that each of these objectives will build towards practice change and improve patient outcomes for our families. So before we get into the meat and potatoes of today's presentation or discussion, I want to just set the stage for you all in terms of what does this look like in terms of maternal substance use disorder and child welfare. As you all may know, recent data highlights that substance use is common among maternal caregivers involved in the child welfare system. Of this population, we know that reports suggest that infants and toddlers are the largest age group, representing about 1/3 of all new entries into child welfare or foster care systems. Now, most of the data that we have related to maternal substance use and child welfare is at the state level. And one more recent report that came out this year was out of Pennsylvania, which revealed that about 58% of cases that involve maternal substance use within the child welfare system were relative to concerns where there was a confirmed use, but the child remained within the home. About 65% of cases were among families who were already receiving supportive in-home services, and about 75% were among families that had a child that was placed in foster care. Likely, it may not surprise you, but parental substance use is a leading driver of child welfare involvement for infants and toddlers, accounting for about 60% of all entries into foster care among children between the ages of birth to age 5. Now, something that I think that's really important to consider is that when we talk about that age range, what do we know about birth to age 5? Well, we know that's a critical period for child development. And that's something that we really have to keep in mind when we're talking about how can we best serve families, specifically those of children of young age. Now, again, substance use is a common factor where child welfare involvement may happen and foster care placements are made. We have to recognize that when we consider many of these families and what they're facing on a day-to-day basis as they're interacting with child welfare, and these different systems, substance use policies may still emphasize punishment rather than support. We know that substance use can result in reporting and potential family separation. And families oftentimes speak of experiencing things like stigma, fear, and especially loss of trust within these different systems, not just within the child welfare system, but also the healthcare system. We know that oftentimes services are frequently fragmented and may feel punitive rather than supportive. And when families are identified as struggling with substance use, we have to remember that systems should not be responding just by automatically removing children. Instead, we should be offering treatment and wraparound supports for families as a whole. We know that when family separation does occur, it does carry significant risk for both the child and the parents. Research consistently shows that punitive responses do not reduce substance use or improve child safety. Instead, they often deepen trauma and perpetuate cycles of instability. And oftentimes, these systems may also fail to address the underlying issues that are relative to substance use. As I mentioned before, we know that it also disrupts a crucial bond that takes place between infants and their caregivers, especially between those ages of 0 to 5. And this bond is essential, again, for child development. Now, there are many leading health organizations that also lean into this, 0 to 3 being one of my favorite organizations. There are early childhood organization that emphasizes that infant caregiver bonding is a critical protective factor for our families. And again, disruptions to that relationship can lead to poor emotional and developmental outcomes. From the work that my team and I have done qualitatively, we know that women also report fear of having child removal or having CPS involvement and fear of child removal. And this was one of the major barriers, or primary barriers for them engaging in treatment services. It was also a major risk factor for them in terms of experiencing overdose and relapse within the pregnancy and postpartum period up to 1 year. And so I think, again, we have to really take a step back and think about not only what's happening very immediately when child CPS or child welfare CPS becomes involved, but what are, again, those long-term ramifications. The National Center for Substance Abuse and Child Welfare reports that families affected by substance use who receive coordinated family-centered treatment are twice as likely to reunify compared to those who are receiving standard fragmented services. And so again, it doesn't help any of us to work within these silos. And so we have to ask ourselves again, are these policies helping families thrive, or are we creating cycles of trauma and separation? And we as healthcare providers have the opportunity and responsibility to change that. Now, likely for many of you, the question often comes up, how do we balance this idea of safety and family stability? In a minute, we'll talk about what are some of the leading drivers in terms of values for each of our professions. But I know across the board, safety is number one for everyone. And so we also have to keep in mind that just because a family is dealing with or experiencing substance use, or maybe even a substance use disorder, that does not automatically qualify them for being a dangerous family or a family that's unsafe. Oftentimes, we need to really consider all of the overlapping issues that may be accompanying that family, or maybe even what are the more important protective factors within that family. It's important for us to recognize that removal is only indicated when there's immediate danger, when we have an inability to provide safe care, the family has an inability to provide safe care for their children, or there's untreated severe substance use disorder. Again, child removal is often correlated with worsened outcomes and increased instability. And so again, we can't approach this as a blanket response when substance use is present. We have to think about the individual needs of that family. So as I mentioned before, when care systems are coordinated across healthcare, child welfare, behavioral health, and community services, outcomes are improved significantly. Parents are likely to enter in complete treatment when they're supported rather than surveyed. Infants experience greater placement stability as well and improve attachment. And families remain engaged in recovery and case planning longer and report higher satisfaction and trust in providers when they're actually involved in the process. The body of evidence that we have available to us underscores that fragmented systems produce fragmented outcomes. And again, sustainable change requires integrated systems of care and approaches that treat families as units and prioritize treatment over punishment, focusing on healing relationships rather than severing them. So, as clinicians and advocates, our responsibility to our families is to champion policies that promote coordination, trauma informed practice, and family unity. Because we know that these strategies are proven and can build and yield better outcomes for both parents and children. Again, coordination across systems means aligning efforts among both healthcare as well as child welfare, criminal justice, and community supports to meet families' needs holistically. So, looking at this from a systems overview perspective, we know that families affected by substance use rarely interact with a single system, right? They're navigating many different systems, including, again, healthcare, child welfare, courts, probation, community programs, all within different systems and with different mandates and definitions of what is in the best interest of a family. Families live at this intersection of these systems, and that care often depends on our ability to communicate and collaborate effectively. As nurses, physicians, social workers, and allied professionals, we often become that bridge between these systems, translating languages, aligning priorities between the different systems, and trying to maintain trust, which is often very difficult, maintain trust with families who may already be feeling judged or unsafe. And so I think it's important for us to remember that we, again, hold lots of power. And I use that word power very specifically because it can be a dirty word sometimes, but I think what, again, I like to think back to Spider-Man with great responsibility comes great power. And so we have to utilize that power responsibly for the families that we're working with. And so if you guys would uh, work with me for just a minute, we'll do a quick word association. When you think about systems like child welfare or the criminal justice system, what words oftentimes come to mind? And I can't see the chat, so I'm asking if someone might be able to read off anything that's coming up um, within our space. Let me see a chat.
Yes, I'll let you know if there's something on
Perfect.
the chat. I see broken, foster care.
Mhm.
I also see, yes, broken foster care. Those are two answers so far. And then we have tension, concerning, neglect,
Yeah.
bad parents, quote unquote, guilt, hopeless, well being, oppression,
Yeah.
human trafficking, unfair, limited choices.
Thank you all so much for those. Yeah, dangerous to say that now. Thank you. Yeah, I think we really have to take a step back and remember that oftentimes these systems are not just working. Um, again, just within themselves, but they have historical context. And many of our families are not just experiencing um, the system with in and of itself for themselves, but maybe there is some intergenerational trauma that's taking place within these systems. As I mentioned before, there's lots of mistrust that happens where maybe they were told one thing by one provider or one caseworker, and then there's a different outcome. In the sphere with where I work, informed consent is a big thing within the hospitals. And families often talk about, they feel like they were misrepresented or they didn't get a true, clear idea of what was going to happen when they disclose their substance use, and they no longer trust the people they're working with. And so I think again, we really have to think not only about what's happening with the family today in terms of their interactions with these systems, but again, remembering that they have long or deep-seated, likely emotional attachments to these different systems based on their lived experience. And likely we do too. And so that may come from just our professional experience, but we may also have some personal experience with working within these systems based on the context of our own lives. And so these things can bring to surface different emotions and biases that we bring to the table that may often shape the ways in which we collaborate with these systems. Briefly, we'll outline these systems and talk about maybe some of the different contexts that we sometimes think about within the overall frame of each system, specifically looking at child welfare, criminal justice, and healthcare. So within child welfare, that is a system that we're working within. And oftentimes we think about their mandates as being that of safety and permanency, right? We want to make sure the system is really keen on ensuring that the infants and children that are within their sphere of influence are safe, and that hopefully they're providing a permanent home for them that is safe for them as well. Within criminal justice, that oftentimes focuses on accountability and rehabilitation for quote unquote offenders. And then within the healthcare space, that oftentimes centers on health and well-being, right? Each system has its own mandate, and although they're different, they are all very valid. And they operate under different definitions for success. And so we have to remember that just because we view success as being one way, these different systems that we may be coming into collaboration with may have a different definition or idea of what success looks like or what safety looks like. But there are overlaps, right? There are overlaps in terms of what these mandates are pushing forward, and where we want to see um, what we want to see accomplished for the families that we're working with. For example, child welfare may see removal as safety, and by difference, we may, as healthcare professionals, may see family unity and healing as safety. But at the crux of this, we all want to see these families safe and thriving. Where else might you see some overlap or shared goals across systems? And again, you can just put in the chat just a few responses that we'll love to see. Just where do you see overlap in terms of the mandates put forward by these different systems?
Okay, let's see what they add in the chat. Okay, I see schools, daycares, daycare
Mm-hmm.
centers, substance use disorders, treatment centers,
Yeah, certainly these are common places where we might see these
probation.
overlap. Yeah, yeah. What about their goals? What are some common goals you think that we might have across these systems? Regular follow-up and follow through. Yeah, that's a big one.
Correct.
Great. Yeah, I think this is so important to recognize like where we might be coming into contact with these different systems, but also where these shared goals taking place. And recognizing this overlap oftentimes helps us to build shared language and help reduce conflict. Our hope is that when we're coming to these spaces that we're not coming in there with a defensive posture, which can sometimes again happen when we might have a certain maybe stereotype or bias about a certain system that we're working with. Specifically when it's in the context of protecting the families that we're serving. I know, some of the common language I hear in the NICU is that this is my family, this is my baby. We put ownership over the families that we're working with. Um, and while that's not necessarily a bad thing, sometimes that can also make us, again, on the defensive when it comes to advocacy. And in order for advocacy to truly happen, again, we have to put down those barriers or those defense mechanisms, and even recognize that we as professionals might have blind spots based on the area or the sphere that we're working with. And so, even though healthcare, child welfare, and justice systems share a common goal, supporting that of supporting families and promoting safety, again, collaboration is often hindered by structural and ethical challenges that may make communication and trust difficult amongst these different systems. So we'll talk about a few of those here. The first being confidentiality. There may be some confidentiality conflicts wherein things like mandates like HIPAA or CAPTA or court mandates don't always align, oftentimes leaving clinicians to feel torn between protecting patient privacy and fulfilling legal obligations. We know that this tension can erode trust and make families, again, fearful of disclosing sensitive information to us as healthcare providers. And so, again, that might put us on guard in terms of how we're able to communicate within these different systems. Again, when we talk about safety and risk, we oftentimes have different perceptions of what risk and safety look like. Again, healthcare systems may define stability as being something like participating in medication assisted treatment, where in other systems, and I've often heard this from parents, systems like child welfare, the courts might see medication-assisted treatment as being a continued risk. So if they continue using medication-assisted treatment, then they're not truly in recovery. And these different thresholds can lead to inconsistent decision making and frustrations across not only systems, but also for the families again. We also know that bias and stigma are always present, especially within the families that we're working with. And we know that mothers who use substances, especially those who are women of color and those living in poverty, are often judged through a moral lens than that of health or of equity. And we know that bias shapes how reports are often made. The evidence points to this many times over in terms of how we're reading a certain case and the outcomes that are associated with that case. Specifically, how we're interpreting the behaviors of that individual. And this can often lead to disparities that we see within the child welfare system and healthcare outcomes. And then finally, we also know that there is a workforce strain across the board, not only for healthcare providers, but we see this especially within the criminal legal system. We know that things like high caseloads, burnout, and turnover across systems limit time for communication and coordination, allowing again families to slip through cracks, unfortunately. And so again, this is not any fault specifically on individuals per se, but we do know that when these issues are occurring across systems, that they can really deepen our inability to work collaboratively. Now, recognizing these challenges is the first step towards building ethical, trauma-informed, and coordinated care that supports both families and professionals. I'd like to take just a minute. Have you guys experienced any of these barriers professionally in terms of your encounters with working across systems?
Okay. Question for the group.
And I'll just say, while people are maybe thinking, I know that this is definitely an issue that I've run into, at the healthcare system that I was working within. We did have a specific partner that we worked with within CPS, but oftentimes that person changed frequently. And so when we had established relationships for our families with this certain caseworker, unfortunately, they may leave the system or the company, and then families were having to reintroduce themselves to new caseworkers or a new liaison. And so that made it really difficult, again, to establish trust for our families. But oftentimes, again, we're seeing a lot of burnout and high turnover in the healthcare system as well. I know, there's very few nurses that I worked with in the healthcare system back when I was on the floor that are still there today. And so that's definitely an issue that we see again across the board. I think I see some coming into the chat.
Yes, some people are saying definitely bias with professionals,
Mm,
and yes, bias in the medical field. Someone is saying these are also factors impacting productive, positive communication.
most certainly, most certainly. Yeah, and so by naming these tensions, we can really start to think about how can we have ethical collaboration, ethically navigate them without compromising, again, patient trust and compliance obligations. And so again, we just have to take a step back and remember that, again, we're all working towards the same common goal. Now, this next slide I'm going to skip because we are going to do a case in just a minute. But I did want to just, again, provide a little bit more information because oftentimes I get questions about mandatory reporting, specifically in here in Texas. Likely you all are familiar with some of the federal laws, specifically out of CAPTA. So I think we want to think about it on this broad scale, but CAPTA includes a requirement that healthcare providers involved in the delivery of care of infants being born with or identified as having affected substance abuse or withdrawal symptoms resulting from prenatal substance exposure or fetal alcohol syndrome. These families have to be notified, or CPS has to be notified of these families. But it does not establish a specific definition under federal law of what constitutes child abuse or neglect. So CAPTA doesn't specifically say that having substance exposure for this infant is necessarily constituted or paralleling child abuse or neglect. Each state really defines what that looks like. And unfortunately, in some of the work that we've done, we see there's lots of variations in terms of how states are defining child abuse or neglect. Moreover, many do constitute some form of exposure as abuse or neglect. But again, this leaves lots of wiggle room for states to define what triggers a notification or report, and whether or not a simple notification of allegation of abuse is sufficient for these families. And so this leads to a wide range of consequences for the families that we're working with. Specifically, here in Texas, Texas does not require routine drug tests, although that is often the case of what happens in the clinical system. But we do not require a routine drug test for mothers, but allows testing if harm to the infant is suspected. Again, lots of gray area. And we have to really think back to who are we thinking about who may be of risk for having substance exposure. Sometimes the people who present to us in the clinical setting may not look like they have a substance use disorder, and so they may not get tested, and oftentimes they may get missed. Versus families who are dealing with maybe other areas of material hardship or other risk factors are more likely to be tested, even though they may or may not have a substance use issue. And so there's lots of gray areas in terms of the Texas law and those families who are being tested. We do know that mandatory reporting is only required when substance use poses a risk to the child. And so again, I think that's another area of gray in terms of what does risk really mean. Oftentimes here in Texas, we specifically see risk as having being diagnosed with NAS or neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. But we really have to take a step back and say, is this specifically risk? Is this a family who is in treatment and we knew that this baby was going to be born with this exposure? Or is this a family that maybe they've had some inconsistent treatment, and we recognize that this family may need some ongoing supports. And so I think we really have to take a step back and ask ourselves, what is the definition of risk and which families are more likely to be at risk? Um, and really again be careful about how we're defining that. And when I say be careful about how defining it, I think that means that we need to bring to the table not just us as healthcare providers and systems, but also the families that are involved in the system, so they can help us define what risk and safety truly mean. We know that researchers found that states that are not in compliance with CAPTA requirements, that many states are not in compliance with CAPTA requirements, excuse me, with only about 14 appropriately identifying the type of substance exposure that warrants notification and the development of a plan of safe care. Just 7 states use the term notify in their CAPTA and CARE policies, while most policies continue to require that states report or refer families, resulting in, again, unnecessary investigations. Now, thinking about, again, the continued legal landscape in Texas back in 2021, there was a bill that was introduced, House Bill 4055, which was a safe harbor for pregnant women. Now, this bill aimed to protect women who disclose substance use by creating a safe harbor or preventing mandatory reporting if certain conditions were met. Within this proposal, the providers would not be required to report if the woman was in treatment or posed no immediate risk to the child. Again, some gray area, but a really good starting place to begin. Again, DFPS would not investigate the child if the woman was enrolled in or had completed substance abuse treatment. So this was all part of this specific proposal. And with this specific House bill, it did pass the House as of May 6, 2021. There were 92 yays, 50 nays, which is really, really good, right? It's a step in the right direction. But unfortunately, it did die in the Senate committee, so it never advanced for a full Senate vote. And my hope is that maybe we can get and garner some interest within this bill being resurrected and maybe reintroduced in a future session, as we do have another legislative session coming up as we meet in odd years. And so maybe that's something that as a collective or a group that we may want to revisit. What are the good points of this bill? What are the points that might have made it die in the Senate committee? But I think this is a great starting place, and we have room to grow in terms of helping really clarify some of the language in our policies to help support families. All right, now I'm going to try to get us through, as I know we have to get to our case, but I do want to talk about some specific strategies for collaboration that we can utilize. Now that we have identified some of the barriers, there are, again, many strategies that can help us move from fragmentation to partnership. These frameworks can be applied across settings, from the bedside to interdisciplinary care meetings and also policy discussions. The first one being utilizing trauma-informed care. Likely many of you all are very familiar with this concept or this terminology, but it reminds us that every interaction can build either trust or erode trust. When working with families involved in child welfare or criminal justice, trauma isn't always visible, but it's almost always present. And so our role is to approach care with the understanding that system involvement itself can be re-traumatizing for our families. Again, they're not just experiencing this one time. Oftentimes, there's intergenerational trauma that's occurred across these systems. And so when we focus on safety, we have to think about this from not just a physical standpoint, but also an emotional standpoint. We have to emphasize empowerment amongst our patients and our families, giving clear information about their rights and their choices. And then we have to reinforce our choice by inviting families again into the decision making, not making decisions for them, right? So they should be a part of these conversations and again, a part of defining what these policies look like. For example, instead of saying something to the effect of, we have to report this, we might say, here's what I'm required to do or what I'm required to report. And here's how we can work together to make sure your needs and your baby's needs are met through this process. And this language can be utilized not just with the family, but across care meeting and care coordination meetings. So that again, that we're using the same language in terms of transparency, which can really transform a mandatory act into a supportive one. Relational autonomy is a really important concept that we can also utilize, recognizing interdependence within our families and supporting shared decision making. Again, traditional models of autonomy assume independence, making decisions alone. But when we utilize relational autonomy, this recognizes that decisions are made in context within families and relationships and within systems of power. For mothers who are navigating substance use and child welfare, autonomy isn't just about making a choice, it's about having the capacity, support, and safety to make their own choices freely. As clinicians, we have the power to uphold relational autonomy by asking about our patients and our families' priorities, validating their goals, and aligning our recommendations within their lived realities. So instead of saying, you need to do this or you need to do that, we might ask, what feels realistic for you right now? And how can we help support that? This subtle shift within our communication styles and our definitions of respect helps to build partnership rather than compliance. Another area that we can work in terms of collaboration is utilizing interagency MOUs or warm handoffs, which create structured and transparent communication pathways. Likely you all are utilizing already MOUs or memorandums of understanding, but we know these partnership agreements can work between hospitals, child welfare agencies, community programs to help define who does what, when, and how. These agreements prevent duplication and confusion and information silos. Oftentimes, our families are so frustrated by having to retell their story or having changes in the level of care or the plan that they need to uphold. But when we have these MOUs, this helps us to establish consistent processes for communication, confidentiality, and shared goals. So one example might be utilization of an MOU to ensure that discharge summaries are automatically shared with the recovery support liaison rather than leaving it to chance. We can also use warm handoffs, introducing patients directly to the next provider or caseworker instead of just giving them a referral. This really moves us from helping families feel supported rather than abandoned. It's the difference between saying, you'll need to follow up with this agency once you leave here, to saying, let's sit down and call them together and make sure that you are connected with this service before you leave today. And then lastly, as we're working within systems, I think it's important that we always ask before we assume. Again, we want to clarify each agency's scope and constraints. And remember that again, we're working towards the same goal. We often believe we know what other systems can or can't do, but we have to recognize that policies and procedures and roles often vary very widely. Just because one organization is working within a certain system does not mean they do the same thing that another organization does. And so we can simply ask, can you clarify how your agency does or define specifically safety within this case? Or what does your reporting process require from your side? Asking these questions can help us prevent miscommunication and again, avoid tension between partners. And I think it's really important to recognize that having this type of curiosity doesn't just clarify, but it also models professional respect and creates a foundation for ethical collaboration. When we integrate these approaches, including trauma-informed care, relational autonomy, structured communication, and mutual respect, we begin to model the kind of system coordination that actually promotes healing. And these micro changes often yield major improvements in coordination and patient outcomes for our families. They're the difference between systems that respond to families and systems that actually support families. And so I won't pause here for right now just to help with time, but just kind of start thinking about what are some communication strategies that you can utilize within your own setting. Maybe thinking about how are we documenting language? What are we doing within shared care meetings? What do our direct contact lists look like? How can we make sure to ensure that this communication is taking place across different systems? And again, that we're not working within these silos. Um, as I mentioned before, we know that clinicians and allied health professionals, we are also oftentimes a consistent thread through all these systems. When families are navigating across healthcare and child welfare, sometimes even the courts, it's oftentimes a nurse or the social worker who is the frontline provider who is maintaining these long and most trusted connections with our families. And that means that we are uniquely positioned to lead change, not only at the bedside or in the clinical setting, but also at the system and the policy level. And so there are different ways that we can continue advocating for our families. First, we can advocate again for non-punitive, family-centered approaches that view substance use through the lens of health and recovery rather than a moral and criminal lens. This advocacy can help happen in many forms, and it can also mean speaking up in a policy meeting when language frames families as non-compliant. Maybe we can utilize language that says something like, instead of being non-compliant, they're actually in need of support. This also might mean that we're championing initiatives that promote treatment access, peer recovery, and family preservation instead of automatic child removal. We
Dr.
know,
McGlothen, I'm
yes,
so
yes,
sorry to
that's okay.
interrupt you, but we're a little bit over the time. Is there a
Okay.
way that we could summarize the coming slide?
Yes, yes, I apologize.
Oh,
Um,
no problem. It's
yes, and so
great information, but we want to move to the case.
yes, no
Thank
problem.
you.
So we will make sure, I will make sure these slides get are available to you all. But again, there are different ways that we can advocate for our families. Again, thinking about how are we working within interdisciplinary team meetings, utilizing harm reduction strategies. And one area that I think that we don't talk enough about is documentation. And so our documentation is oftentimes used in terms of collaborating with across systems. And so we have to be really mindful that that documentation that we're doing is objective, factual, and non-stigmatizing. And so I think this is an area that we can continue to look at in terms of stigmatizing language within documentation and the outcomes that this might have for families. A quote that I think is really important for us to think about is that we can't dismantle what we don't understand. And so we have to begin working across the board, across the system, so that we can really understand what each system does, so that we can work more collaboratively. Just some reflection takeaways. Think about one step that you can utilize this month to help you improve these different navigation for systems and families. I think hopefully we talked about a lot of them here today, but hopefully you'll go back to your own organization and think about how can we look at the policies that we have in place to ensure there's clear communication across the board and across systems. There are some key resources here. I won't go through them, but one that I do want to point to is a new resource that's available through 0 to 3. It's called A New Way, Reimagining Substance Use Policies to Support Families and Reduce Infant and Toddler Entry into Child Welfare. And I really like this resource because it lists out the different systems that are working within this space and how we might partner in terms of looking at advancing policies to be more supportive towards families. And so when we get a break, or I might send it out to our experts and group leaders, I'll make that resource available as well. Just a closing message, remember collaboration isn't optional, it's essential for health and healing. And so every conversation, every report, every discharge plan really is an opportunity for us to, again, to rebuild trust and dismantle stigma for our families. And so I really just thank you all for your engagement during this conversation as we get into the case study and your commitment to families and navigating these complex systems. And with that, there are resources and references again that will be made available. And so I'm going to go ahead and close this out here. My apologies for going over.
No, no, it's great information. And I think that we're all very interested in the presentation. I think there's a lot of resources. And like Dr. McGlothen said, we're going to be sending to you this PowerPoint didactics with all those resources and information as well. So we can take 1 or 2 quick questions and then we can move to the case, which in this case, of course, and that's wonderful, is in a way a continuation of the presentation because it's presented by Dr. McGlothen as well. Any questions or comments from the group?
I put a bunch in mine. I'm Joy, and
Yes.
I put so much chat in there. I already Googled you. Everything you said, spot on. I just learned this analogy about if you're a rock person or a clay person, and everyone might have heard this before, but I hadn't. And this is just proof that we all need to be clay people. We're movable with warmth, right? We can reshape futures, reshape our thoughts. So that's a brief summary. Everybody should look up that little analogy.
I love that. Thank you, Joy.
I loved it too.
Hi, this is Dr. Reese. Thank you for that amazing presentation. I think one thing that is I'm getting um, the big message here is when women have a medical issue, like let's say you have a patient who has not been taking her diabetes medication and she has unmanaged diabetes, she shouldn't be afraid to go to the hospital, right? She shouldn't be shamed when she tell her doctor, actually, I did not take my meds because I didn't have a car, I didn't have, well, I forgot. She's not ashamed to do that. She's going to go and we're going to get on a treatment plan. But for
Mhm.
substance use, someone that relapsed or is using, there is so much shame. So they're not going to the hospital to get help because a lot of times there's real consequences of doing that.
Mhm.
And the last echo that I presented, which is recorded on the website, I share with you that 70% of women that died from overdose were not in the healthcare setting. That is so much. That's almost double. Meaning, when someone has a medical emergency, they know to go to hospital. They know they're going to be safe. They're going to get treatment. But when someone is using, they are afraid to go, and we're missing so many opportunities of intervention. And I feel that your lecture today just really just again highlighted that point that we should be our role in the healthcare system is uniquely different than the
Yes,
role of the other two systems.
most certainly. And again, so important for us working across those systems because these issues are not taking place again in the clinical setting, like you said, they're out in the community. Most certainly.
Thank you so
I,
much, Dr. Reese.
um,
Yes, go ahead, Dr.
Yeah,
Humphrey.
I just thought you raised a really important point that has come up in my clinic often, but I haven't heard talked about, which was just because someone's maybe using a substance and has children doesn't necessarily mean it's reportable. This has been a point of contention, and that I've had some parents say, yes, I am using whatever substance it is, but I'm not using it at the house. I always go to a buddy's house. It's not around the kids. My mom watches the kids if I'm gone, like,
Mhm.
and it's like, okay, is that any different than someone getting drunk on the weekend, like a parent, at
Yeah.
a barbecue, right? And that's not reported.
Mhm.
So I feel like this is something that I've seen cause a lot of dissension among staff members, when some people want to report and some people don't. And it's like, well, it's in the urine drug screen, but they say never use around their kids. It's just really complicated.
Yeah.
And I like that you touched on that. Not that we have hard and fast answers to all of these, but it isn't always black and white. Just because
Mhm.
someone has meth in their urine drug screen and has a kid doesn't necessarily mean we need to call CPS. Or it might. I don't know. I think that that's when talking to the family and having that open dialogue is really important.
Yeah, I think you hit the nail on the head. That open dialogue is so critical to understanding what the context of this looks like. Yeah.
And I know one thing that we've done before when that's happened and there's been some concern, is like we have called, I can think of one patient in particular. We called her mother. Her mother came to the appointment, the grandma that was watching the kids, and she disclosed to her mom, hey, I'm using these substances. I'm going to be open with you about that. Every time I use, I will, you know, will you watch the kids or something? Not a
Mm-hmm.
great, not the best plan, but she was ensuring
With
her
the
kids were
plan.
safe and
Mm-hmm.
doing it in a responsible way. And that was, something that the staff was comfortable with, knowing that mom knew what was going on and mom was taking responsibility for the child's welfare. I don't know. Those are really hard situations, but
Yeah.
I like that you brought it up.
No, that's a great example of a great harm reduction technique. I love that. Thank you for sharing.
Well, I think for now we can start sharing the case form. And Dr. McLaughlin, if you could briefly
Yeah.
walk us through this case, and then we're open again the floor for suggestions from the group.
Sure. So I modified this case for something that was recently in the news that came across my thread. But I'm going to read just a little context and we'll go through the case form here. So our case involves a 32-year-old single mother of two. She has a 7-day-old infant who's currently in the NICU. She also has a 9-year-old child who has an active CPS case that has been open for about 2 years. The mother reports that her CPS caseworker recently informed her that the case was likely to be closed soon due to her progress and consistent engagement in services. Now, the patient does have a history of opioid use and has been in stable methadone maintenance treatment for 3 years. She's engaged in prenatal care. She's remained compliant within her methadone program. She's attended counseling and recovery support groups. But following her delivery, both the mother and the newborn again tested positive for methadone, which was consistent with prescribed opioid maintenance therapy. Despite this, the hospital social worker made a CPS report due to positive toxicology screens. Regarding her past CPS history, the mother worked 2 jobs to afford rent and basic needs. Because she lacked access to affordable childcare, she left her then 7-year-old, a night with a nightly safety routine until she returned home from work approximately at 11:30 p.m. One evening, her car broke down and she couldn't get home, and her child was home longer than usual. And so a neighbor noticed and called authorities. By the time she got home after midnight, CPS and law enforcement were present. Her child was taken into custody. She was later charged with neglect of a minor, initiating involvement with the criminal justice system. While she's since regained custody, she's afraid of this new report, which may affect her open child or CPS case for her oldest child, and she's fearful of what may be the outcome in terms of having this new case. And so this mother, in terms of mental health symptoms, she does have a history of depression, does not have mania, does have a history of anxiety. They're unknown in terms of suicidal ideation attempts or non-suicidal self-injury. There are other symptoms of other symptoms that are relevant, including sleep deprivation. Sorry, I'm also a new mother and experiencing sleep deprivation as well as I'm trying to read. Um, Fear, shame, and trauma symptoms. Yes, she does have a history of trauma. There are no disclosed use of stimulants, nicotine, alcohol. She does say that she used cannabis or spice 2 to 3 times weekly. Um, Continuing on with substance use, none disclosed for NDMA. Again, she is in long-term substance use treatment for opioids, including methadone maintenance. And she has not disclosed any use of benzodiazepines or other substances. Her primary behavioral health diagnosis for SUD is opioid use disorder, moderate. Secondary substance use none reported. Again, primary mental health diagnosis is moderate depression, and then secondary moderate anxiety. In terms of behavioral therapies, she has been involved in counseling in the previously as well as presently. She is again receiving methadone and has ongoing maintenance treatment presently. She has not received any inpatient services. Her only current inpatient treatment is due to her current admission for childbirth, not substance use treatment. In terms of mutual aid and support groups, she has in the past received this, also recovery support meetings, parenting classes, and she also has, again, legal supervision and CPS case planning requirements that intersect with her treatment. In terms of risk reduction services, she does have naloxone made available to her for preventing overdose, education about postpartum relapse risk, the safety of concerns in terms of methadone and breastfeeding. She's received guidance on that. Safe sleep, NICU transition planning, support for transportation, housing stability, and legal advocacy referrals have been made. Her PDMP has been checked in terms of pertinent findings. Again, she maintains engagement in methadone despite having severe other issues that she's facing in terms of material hardships. Current medications, methadone 76 milligrams daily, prenatal vitamins and acetaminophen or ibuprofen for pain for postpartum. No major surgeries disclosed, just a prior birth, vaginal clearing in 2016. In terms of medical comorbidities, just the typical postpartum, I shouldn't say typical that I don't want to invalidate that, but postpartum physiologic changes, sleep deprivation. Again, her baby is in the NICU requiring maternal visitation coordination, possible anemia, and chronic stress related to poverty and legal system involvement. And so some questions that we might consider are how can we support safe maternal engagement and care amid active CPS and criminal justice involvement? How do we provide trauma-informed postpartum and substance use disorder care while addressing systemic barriers, including poverty, child care, and lack of support? And then what are some of the best practices that we might utilize in terms of cross-system coordination between the NICU, child welfare CPS workers, and substance use treatment?
Thank you, Dr. McGlothen. So let's hear some ideas from the group. Reunification, trauma-informed care. You guys can unmute yourself so you may add on the chat any ideas that you may have.
This isn't exactly the question, but when I was reading through the case earlier, I'm in Waco, Texas, and I know we have a program here called Together for Good, which is in a few different states. And I think there's similar programs with different names around the country. But it's a I would think of it more of like a family mentoring program where high risk families may or may not be involved in CPS, but they get paired with other families that and they can watch your kid for the weekend or bring you a meal, or hey, you've got a stomach bug and you've got 4 kids and have nobody to call, you can call this family. And it's supposed to be that added support for people that don't have a lot of support. And I was just thinking of that with like this mama, like she's working late, she's doing her best, like having a program like this where you have someone that you can call, like, hey, can you go hang out with my kid for a few hours these nights of the week or something. I think more of these are popping up around the country, but just that some of these moms just and dads just need a little extra support, right? And that's all they need. And they're right on that edge. So
That's amazing. I did some qualitative research looking at barriers to prenatal utilization and treatment services for families involved in mandatory reporting and CPS. And that was one of the main things that came out in terms of intervention they wanted to see. We're having families who have been in the systems and that could help them navigate those systems. So I love that. I'm going to look at that program. And I also see Joy put in Safe Families. Definitely. I hadn't heard of that one either, but I'm going to look that one up too. Thank you.
Yes, Joy, do you want to speak a little bit more about that, about
Oh,
Safe Families?
sure. Sure. It's very similar to what Dr. Humphrey was saying. I think this woman is a woman in progress. Like, she has really had 3 years of MAT support moving forward. This is just was so heartbreaking to hear that, the car broke down or she had no way to get home and the child was left there. So yeah, if she had someone she could call, is there an emergency line in Tucson, Arizona, we have like Healthy Families or the Sense program. Like, is there somebody within the DCS resource that could be after hours to say, this is what's going on, I'm working on a plan, I'm going to be there, just that extra safety net, because this could happen to anyone. This could happen to anyone. And it's just, I would love for there to be some other safety net so that she doesn't have to face this additional trauma because she had her car break down or no bus available. So it's called Safe Families here in Arizona. I think it's in other states. Obviously there's mirrors. And I just love that Dr. Humphrey brought it up because it'll inspire all of us in our in our countries or counties to look and see if it's there.
Junda, you have Junda Wu. I saw you added something to the chat. Would you like to unmute and tell us a little bit more about that?
Oh, just that the generic term for this is sometimes called a crisis care nursery.
And Dr. Alag, you had a comment as well.
Yeah, I mean, I just wanted to see if there's ever an option. I mean, we do have one at Texas Tech here itself, where you can send your kids to daycare and they're sometimes more reasonable price, but that's not always an option for all our patient population where they work. But I wish that was another option that where, she could take her kid and leave the kid safely. Again, they could be really expensive, and that's another thing you need to afford. But I wonder, did she have any social support, or like, does she connect with church or any of those resources at all, or no?
In this situation, that's a great question. This situation, no, she did not have any familial support nearby. She had left an abusive relationship, and so she was in a new, sorry, my little one's crying in the background. She had left an emotional abusive relationship, and so she was in a new town trying to separate herself from that. So she did not have that support nearby. So I think having one of these other resources would have been definitely made a difference.
I just
I don't
wanted
know
to
if
say
this
you're a
is
new mom. You're doing phenomenal for that. Sorry, I interrupted you.
No, no,
But
no.
being a new mom, you're doing phenomenal. So great
Yes,
work.
I was gonna say, and congratulations, by the way.
Thank you.
So I think in the interest of time, I'm gonna breeze very quickly through the announcements, and then we'll go back to Dr. Reese, and she's gonna give us a little bit of a summary of some of the recommendations discussed here. Remember that in order to receive credits for today's sessions, you must have an active account with the Texas Tech University Health Science Centers. After that, all you have to do is text the code CLAIM 39938 to the number on the screen. And please don't forget to complete your post-session survey. Next. And please let us know what you think about our program. We have this annual Health Resources and Services Administration HRSA evaluation survey. Your feedback on this survey is important in supporting the program's goal to increase access to behavioral health services. We're sharing the link with you. Next, please. And CSTAT is pleased to introduce Proof and Progress, a recovery science webinar series. This is a 6-part online learning series. We're sharing the link with you. That's going to take place on Friday, December 12th at noon. Next. And Terry Scogging will be joining us and presenting for us on Tuesday, December the 16th on challenges, opportunities, and the role of hospitals in rural health. Another one of those great sessions that we have leading to our annual symposium. Next. And as you all know, we're having the symposium on March 2 and 3 here in San Antonio, and we are inviting professionals across substance use and behavioral health to submit presentations and poster proposals. Please complete the form we're sharing with you on the chat, and we'll get back to you. We're actively looking for presenters. And at this point, I think Jen has some announcements to make. Jen, whenever you want to, you can take it away.
Okay, thank you. I'll be brief. So I'm just going to give you a quick overview of the Texas Perinatal Psychiatry Access Network, which is known as PeriPAN. We're designed for clinicians who see pregnant and postpartum women. PeriPAN was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading cause of pregnancy-related deaths. A lack of access to care and provider shortages further compound this problem. Next slide. PeriPAN is anchored by 12 regional medical schools and health-related institutions across Texas, as you see on this map. Signing up is super easy, and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Next slide. This is our, this is our 2025, I think. Well, we do have starting in January, we'll have a new fresh lineup of sessions that start in January. The webinars that we do complement these ECHO series by offering a deeper clinical insight and opportunity to learn directly from experts in the field. Next slide. And then this is the list of topics and dates for upcoming lunchtime maternal mental health echoes, which are held on the first Tuesday of the month. We invite you to join us in future sessions to continue learning about these important topics. And I think that's all I have. Back to you.
Thank you, Jen. And Dr. Reese, very briefly, let's go to summary. Thank you.
Thank you. To summarize, I think it's important to remember our role specifically for the patient. And so when we are confused about our role, just remember, if your role is a healthcare system, what is your role for that? And knowing the rules, because you'll find out most people are very confused about it, even sometimes the hospital policy. So you knowing the requirements is an important part of knowing our role and supporting our patients. Thank you so much.
Thank you, Dr. Reese, and to all of you. We went a little bit over the time, but it was a great session. Thank you to all. Merry Christmas or happy holidays to all of you, and we'll see you in January. Have a great rest of your day. Thank you.
Thank you. Take care, everyone.